Hello guys, today the topic of discussion is autosomal dominant polycystic kidney disease. So basically, before going into this topic, we should know about the classification of autosomal, or for that matter, any cystic kidney diseases. So broadly, if we classify the cystic kidney diseases, so they are classified as hereditary diseases and non-hereditary diseases. Among hereditary diseases, on the top we have autosomal dominant polycystic kidney disease, or from that medullary cystic kidney disease, von Hippel-Lindau, and tuberous sclerosis. Among non-hereditary causes, we have acquired cystic kidney disease, medullary sponge kidney disease, and multi-cystic dysplastic kidney. And there are some conditions in which there is localized renal cystic diseases. So, by definition, autosomal dominant kidney disease is a multi-system disorder, which means that there are multiple cysts. Apart from renal involvement, it can involve any other organ, including liver, which is most commonly involved, and pancreas and lichenoid membranes. Regarding the genetics of autosomal dominant kidney disease, so it's heterogeneous, and there are two commonly known genes, which are PKD1 and PKD2. PKD1 is located on chromosome 16 and PKD2 on chromosome 4. The commonly associated protein which is involved in the pathogenesis of this condition is polycystin 1 and polycystin 2. They play a role in maintaining the normal ciliary function in the tubular epithelium of the kidney. But once this function is lost, so it tends to form cyst in the lining. There is outpouching of if the ciliary function is lost, so there is outpouching and it results in cyst formation. But it's not as simple as it seems, but because there are multiple pathophysiological changes which are involved. Broadly, if we classify or if we say the pathophysiology of this condition, so polycystin is a membrane signaling protein, and it also the polycystin 1 and polycystin 2 is a calcium permeable channel within the cilia of the renal collecting ducts. So if we cut it short, so it normally maintains the homeostasis of the renal tubular epithelia, and if this homeostasis is lost, so it leads to disruption, it leads to uncontrolled or dysregulated cell growth, and this proliferation of the cell leads to enlargement of the or formation of the cyst in the renal tubular epithelium. Normally, this is the epithelium. If this is lost, so what happens that there is outpouching of the this epithelial lining, and ultimately it leads to local tissue ischemia, and it leads to scarring and progressive end-stage renal disease. So this is a brief schematic diagram which represents the formation of the cyst in its possible pathogenic way. Firstly, there is a mutation of the chromosome of the polycystin 1 and 2, and it leads to abnormal mechanosensation of the tubular cilia, and there's altered calcium flux as well. So if there is disruption of both these two, along with some mutation in the chromosomes, so it leads to abnormal extracellular matrix generation, abnormal cell proliferation, and fluid secretion. These are the possible mechanisms, and it leads to cyst formation, and ultimately glomerular damage and interstitial fibrosis and inflammation. So if coming to the differences between ADPKD associated with PKD1 and ADPKD with PKD2, so the possible pathogenesis is that the gene location, we know already that it's on chromosome 16, and this is 4. The protein product is polycystin 1, and then 2. The year of discovery, which is relevant information here so far, so it's like 1994 and this is 1996. So far, pathogenic mutation, and what's the function of the protein product, so we clearly understood this thing. And meanwhile, what's the mean age for this ESRD, so it's like 58.1 and this. And there are numerous cysts which are present and associated with this PKD1 mutation. Okay, so let's come to the clinical manifestation. So clinically, we have in renal manifestation and then extrarenal manifestation. Among renal manifestation, this is a table which is taken from a comprehensive book of nephrology, which shows that broadly the renal manifestation can be classified into 4 categories, which are functional defect, patient mostly present with hypertension. Pain is a common presentation in the nephrology OPDs, and there can be reduced GFR and then possible end-stage renal disease as well. So among the functional defect, which is usually neglected, and sometimes the patient does not present with these, but it's the most common presentation in children. So there's concentrating defect, and partly because of the reduced renal blood flow. Most commonly, the patient usually present later in life, and the common presentation is target organ damage, which includes cardiovascular, cerebrovascular, or peripheral vascular conditions. Among the pain, the most common is cyst hemorrhage, and the patient usually presents with gross hematuria. Sometimes it's visible hematuria, and sometimes it's microhematuria. So the patient usually present like that, and apart from that, patient can have renal stones, repeated infections, and sometimes heaviness in the flank region because of the bulkiness of the kidney itself. And last but not the least, patient can present with reduced GFR, which is signified by the derangement or decline in the GFR and derangement in the renal functions. So a patient has to keep an eye on that, just to be know the prognosis or the disease itself progressing towards the end stage. So the patient should keep an eye on his renal function, provided that he knows there is the early diagnosis for this condition and he's on medication and he's taking proper treatment with the proper follow-ups. This is another the renal manifestation which is taken from an article. So as I told you, that concentrating ability is usually in children, 60% of the children, and it's the earliest manifestation in children. And hypertension is usually the presentation in 50 to 70%, and it presents prior to the decline in the GFR. Like this can be an early pick in patient who has hypertension with the presence of deranged renal function is present or not, but it should be taken into account. Screen the child with family history of ADPKD from 5 years of age, and then at 3 years interval if the child is negative for any kind of cyst in the kidney. Patient can present with the ESRD, or patient can become ESRD, and it presents most 50% of the patient by the age of 60. Proteinuria is usually not the presentation, but since there is progressive renal disruption, so it can lead to proteinuria, and it's usually the prognostic marker. Abdominal pain, flank pain in patients, 60% of patients, it can be acute, it can be chronic, and the patient can go on and off with this kind of complications. Stones are common in 20 to 35% of the patient. Usually, it's asked that what is the commonest type of stones in these kind of patients. So there are two types of stones. Uric acid among the most common, but calcium oxalate is also present. So probably we can say that two types of stones are present. Cyst hemorrhage in 60% of the patient, and usually it's self-limiting. Up to a week, you should observe the patient, provided you give pain relief to the patient. But if it goes beyond, then think about some other causes as well. Infections in 30 to 50% of the patient, most commonly in women, and renal cell carcinoma is rare, but it's there, so you should keep in mind. Renal sizes, it increases with age, and almost 100% of the patient, and the severity of the structural abnormality usually presents with pain, hematuria, hypertension. There can be a massive renal enlargement which can lead to compression of the compressive symptoms in the form of inferior cava compression, or digestive symptoms like dyspepsia or indigestion, things like that because of the compression effect. So regarding this, there is a study which is known as CRISP study. It was done on 241 patient. This suggests that annual MRI has shown that total kidney volume and cyst volume increase exponentially. So this was a study performed, and it shows that the cyst volume and the kidney volume goes hand in hand. Okay, so as we know that we are studying the renal manifestation, so pain is the most common, and it's usually present, and it's usually the most hampering effect of the patient daily lifestyle, provided this disease itself is very depressing, but it can halt all the daily routine. So it's usually seen acutely, and patient needs to get rid of it, but it can include, if it's severe, so it can lead to hemorrhage, or it can lead to infection, and even stone formation. And really, it could be a tumor. Like if you're suspecting that the patient is this polycystic kidney disease, most of the time, if the patient is having hematuria, it's usually less than a week. So okay, that's fine, but if it goes beyond a week, so you should think out of the box. Hematuria and cyst hemorrhage, it presents with 40% of the patients. So the most common differentials which we need to explore is cyst hemorrhage, stones, infection, and tumor. So when there will be visible hematuria, so you should think like if the cyst is communicating with the collecting ducts, so it can result in the collecting system, it can result in micro hematuria. But if it's not the case, it can present with microhematuria. Even retroperitoneal hemorrhage, it's a potential emergency in ADPKD. So as I said, that most cysts resolve within 7 days and in 2 to 7 days. But if it's not the case, like if it's longer and the age is greater than 50, so you should exclude the neoplasm. Infections are also the common presentation. So it's usually overestimated because most of the time patient present with sterile pyuria, but patient can present with cystitis, acute pulmonary and cyst infection. What's the most common bug is causing the infection in ADPKD? So it's usually the E. coli, Klebsiella, and Proteus species. And Enterobacteriaceae is also one of the notorious bug which is usually found in this cystic condition. Usually it's the retrograde infection that's from the bladder going upward and causing complications. So there are some studies experimentally, if we are suspecting UTI, so we do our basic workup in the form of urine routine examination or urine cultures. But if the cyst is infected and we did a CT and or for that matter MR, they are like a good source for detection of anatomic localization of the cyst. But to differentiate between infected cyst and a normal cyst, a benign cyst, so there is a modified imaging or more advanced imaging which is called F-label fluorodeoxyglucose positron emission tomography. This is basically more advanced and usually not done, but it's if we are confused about diagnosis and we just want to know. So this is the imaging which is usually cause the detection, or you can say it can detect the infected cyst, because the glucose, if there is infected bug in the cyst, so it can increase uptake, but it's not usually conclusive because the increased turnover and increased cell growth can be due to other conditions. Malignancy is one of them. So coming to stones caused by these so 20% of stones are associated with this condition, and most commonly, as we said, that uric acid is most common with ADPKD, and some other stones are also present in the form of calcium oxalate. Both can also be present. This is partly because the pathogenesis itself is because of the stasis of the urine and or because of multiple or repeated infections. So that could be the case. Usually diagnosed with dual energy CT. Not the stones, but in order to differentiate between the calcium and uric acid stones. So this is the modality with which we can distinguish between the both.